Hello friends, today we are going to discuss Guillain-Barré syndrome. Now, first and foremost, it is important to know the correct pronunciation of Guillain-Barré syndrome. It is not Guillain-Barré, it is Guillain-Barré. The double L is silent here. It is important to remember the correct pronunciation. So it is Guillain-Barré syndrome. Now today we are going to discuss it under the following headings: introduction, epidemiology, pathophysiology, clinical features along with the atypical variants, differential diagnosis, lab findings and diagnosis, treatment and prognosis. So Guillain-Barré syndrome is actually an autoimmune disorder. It is an autoimmune disorder that is a post-infectious polyneuropathy. It is also known as AIDP, autoimmune demyelinating polyneuropathy. It is mainly motor, but it may involve the sensory as well as the autonomic nerves. So it is an autoimmune disorder mainly caused by molecular mimicry with certain inciting factors that we will later study in the pathophysiology. Now Landry was the first one who described it, and Asbury was the one who discovered inflammatory demyelinating lesions. Asbury is a name, is the person after whom the diagnostic criteria for Guillain-Barré syndrome has been named. Now, Guillain-Barré syndrome is now the most common cause of acute flaccid paralysis in India. Earlier, it used to be polio. Now, the sensitivity of surveillance of the polio program has to detect at least one case of non-polio acute flaccid paralysis annually per 1 lakh population in less than 15-year-old. But since India was endemic, so it was considered that 2 cases per 1 lakh population should be detected annually per 1 lakh population. So most of the acute flaccid paralysis that is detected is mainly Guillain-Barré syndrome. So the incidence of the Guillain-Barré syndrome is around 0.34 to 1.34 cases per 1 lakh per year. And also we must remember that the male gender is more susceptible to developing Guillain-Barré syndrome. Now, there's also a pattern that is observed. Mainly we see two patterns. One is the acute motor axonal neuropathy, which is the AMAN, and one is the acute inflammatory demyelinating polyneuropathy, which is the AIDP. So the AMAN pattern, which is more dangerous, always remember that the AMAN pattern is more dangerous. It always has some seasonal involvement. But the AIDP, it lacks a seasonal variation. So that's about it. Now let's come on to the pathophysiology of Guillain-Barré syndrome. So there is an infection by, let us say, a bacteria, for example, the Campylobacter jejuni. Now there are some antibodies that are produced as an immune response against the Campylobacter jejuni. Now this will lead to the production of certain antibodies, and these antibodies will cross react with the nerve, some certain areas of the nerve. So the two patterns that are talked about, one is the AMAN and one is the AIDP. So what will happen is that the antibodies which are produced in AMAN will actually be the anti-GM1 and the anti-GD1A antibodies. They will bind to the axolemma, leading to complement activation and formation of the membrane attack complexes, which will lead to nerve damage. They will damage the axon of the nerve. But in the AIDP pattern, the antigens, they will be located in the myelin sheath, and they will lead to the inflammation and destruction of the myelin sheath, causing the demyelination. So it is mainly caused due to molecular mimicry. The antibodies which are produced against Campylobacter jejuni or any other inciting factor are causing cross reaction with the certain areas of the nerve and causing these patterns in the Guillain-Barré syndrome. So here's a table. This table shows the different antibodies which are found in different types of or different patterns of Guillain-Barré syndrome that we see. So in AIDP, the actual antibody has not been discovered yet, but more commonly the GM1 antibody is found. In the AMAN, that is the acute motor axonal neuropathy, it is more common in the developing countries like India. In it, we must remember that GM1 and GD1A antibodies are more commonly produced. So the GM1 and GD1A antibodies are characteristic of Aman. And there is an important variant which is the Miller-Fisher syndrome, in which the GQ1B and the GT1A antibodies are produced. GQ1B and GT1A antibodies. Now an easy way to remember these antibodies is that the GQ1B antibody, which is produced in Miller-Fisher syndrome, is actually found in the oculomotor nerve. Now when these antibodies will be produced, they will attack the oculomotor nerve, hence the external ophthalmoplegia that is seen in Miller-Fisher syndrome. So we can relate the antibody with the clinical picture. And the GM1 antibody, which is produced in the AIDP pattern, that is the acute inflammatory demyelinating polyradiculopathy, actually affects the ventral root. It is more commonly found in the ventral root of the nerves, hence the motor involvement in Aman and AIDP. Hence the motor pattern is more pronounced in Guillain-Barré syndrome. Now let us talk about the clinical features. So what are the inciting factors? An infection like a gastrointestinal infection caused mainly by Campylobacter jejuni and H. pylori. A respiratory infection caused by, let us say, Mycoplasma pneumoniae, and systemic infections are also common, caused by Zika virus, infectious mononucleosis caused by the EBV virus, and Lyme's disease. These are also found to be causative. Also important is certain immunizations. Immunization against rabies, influenza, even hepatitis B has been found to be an inciting factor. Now what happens is, once the inciting factor happens, around 10 days or 2 to 3 week time is required for the production of antibodies. Now once these antibodies are produced, they start their pathogenesis, they start affecting the nerves, and we see weakness. Now the weakness occurs. It is important that in AIDP, or let us say in Guillain-Barré syndrome, this weakness, it reaches its height, its nadir, in 4 weeks. This 4 week is a very important time to remember. 4 weeks may it will reach its nadir, and then the weakness will slowly improve. If this time is more, then it is no longer acute inflammatory demyelinating polyneuropathy. It then becomes CIDP. So it is important in most cases of Guillain-Barré syndrome, the weakness reaches its maximum peak in 4 weeks. Now, here are certain patterns of weakness which are seen in different variants of Guillain-Barré syndrome. These I will discuss later once I talk about them. The initial symptoms in Guillain-Barré syndrome. So, in the initial symptoms, the first symptoms that a patient comes to us is, or they remember, is numbness. They feel numbness and they feel paresthesias. This is because the antibodies have started reacting with the nerves, which is followed by weakness. Now we must remember that this weakness is ascending. It first will involve the lower limb, then the trunk, then the upper limbs, followed by the bulbar muscles. Now, involvement of the extraocular muscles is rare, but the facial nerve involvement, the facial muscle involvement, bilateral, has been seen in a lot of patients. So we have to remember that the extraocular muscle involvement is rare, but facial muscles bilaterally may be involved. Also, we must remember that there are features of radicular pain. A lot of children, they will present with antalgic gait, with pain, and we might think that the child is just acting, or the child is just having antalgia and pain, but this pain is actually because of GBS. So radicular pain, myalgia and irritability is also very common in GBS. We must remember this. Also, earlier literature used to say that if there is bladder involvement, rule out GBS. That is not so. Bladder involvement may be seen in around 10% cases of GBS. So we must remember this. Also, early areflexia is an important feature of GBS. Now, how to remember this? It is actually, GBS is symmetric, ascending, progressive paralysis. Areflexia that progresses over days to weeks and reaches a nadir in about 4 weeks. Now I talked about two patterns. One is the AMAN pattern and one is the AIDP pattern. As I told earlier, the AMAN pattern is more rapid, it is more severe, it is associated with more ICU admissions. How to remember that AMAN is more severe? AMAN is involving your axon. Once there is axonal damage, there is no regeneration. But in the demyelination, if there is demyelination, remyelination can occur and the prognosis will be better. But once your nerve is damaged, your prognosis is poor. So this is how we can remember this. Also, I will talk about one variant, which is the Miller-Fisher variant. This is a good variant. It has actually got excellent prognosis and full and rapid recovery is seen in the Miller-Fisher variant. This A1 variant, why I said has more ICU admission, that is because respiratory muscle weakness, diaphragmatic paralysis. Diaphragm is responsible for 90% of your respiration. This diaphragmatic involvement occurs in A1, and that is what is responsible for the ICU admission here. Now, there are in some cases autonomic nervous system might also be involved, which will cause a lability of BP and heart rate. BP might be low, it may cause postural hypotension or hypertension, dizziness, arrhythmia. All of this may be seen. If there is a bulbar involvement, if your 9, 10, 11, 12 nerves are involved, it may cause respiratory insufficiency, dysphagia, facial weakness. If your vocal cord paralysis occurs, then there will be hoarse voice and dyspnea. Now, I have been singing about Miller-Fisher syndrome since the starting. What is Miller-Fisher syndrome? Till now you must have remembered that it has GQ1 antibodies in it. Now, it is actually AAA, 3A. That is how I remember it. So, acute external ophthalmoplegia is seen in it, ataxia is seen, and areflexia is seen. This acute external ophthalmoplegia, the sixth cranial nerve is the most commonly involved in it, and it also has urinary retention and incontinence. So this is one variant of Guillain-Barré syndrome in which urinary retention and incontinence is seen very commonly. Now, related to this is the Bickerstaff encephalitis. This is also a variant of GBS in which, along with features of Miller-Fisher syndrome, hypersomnolence and extensor plantars are seen. So this is the Bickerstaff encephalitis variant of Guillain-Barré syndrome. So there was this figure showing the patterns. So the first one shows the Guillain-Barré syndrome, the classical pattern in which quadriplegia will be seen, the involvement of the entire body is seen. There is the paraparetic variant where only the lower limbs are involved. There is the pharyngeal cervical brachial weakness, in which, as shown in the figure, the pharynx, the cervical region and the brachial weakness is observed. There is this Miller-Fisher syndrome in which only external ophthalmoplegia is seen, and there is this Bickerstaff brainstem encephalitis in which features of Miller-Fisher syndrome along with hypersomnolence are seen. So I was talking about chronic inflammatory demyelinating polyneuropathy. In this also weakness and paresthesias are present, but these are present for more than 4 to 6 weeks, and these might recur, or this may be a progressive disease. So if the disease is progressing more than 4 to 6 weeks, or if the disease is occurring intermittently, then we label it as chronic inflammatory demyelinating polyneuropathy. We must remember that the weakness is more severe and hyporeflexia or areflexia is present. Also, in CSF, there will be no pleocytosis, but the proteins will be increased. There's also a variant called the congenital GBS. This congenital GBS presents in a newborn with hypotonia, weakness, areflexia, but in the absence of maternal neuromuscular disease. It is not that the antibodies of the mother have crossed the placenta and caused the GBS in the child, but we must remember it is rare, but its prognosis is good. It recovers on its own. So the lab findings and diagnosis in GBS. I talked about Asbury. The Asbury criteria of Guillain-Barré syndrome should be remembered. Now, features which are required for the diagnosis of GBS is there is a progressive weakness of both the arms and legs along with areflexia. Also, features which strongly support the diagnosis are progression of symptoms over days to 4 weeks, relative symmetry of the symptoms, mild sensory symptoms or signs, cranial nerve involvement, especially bilateral weakness of facial muscles, recovery beginning 2 to 4 weeks after progression ceases, absence of fever at onset, high concentration of protein in cerebrospinal fluid with fewer WBCs, typical electrodiagnostic features, and pain which is often present. All of these are discussed in the Clinical presentation, these just need to be remembered. They will also help us in differentiating it from similar conditions which present with weakness. Once we remember the Asbury criteria, the patient is unlikely to be a case of GBS if there is a persistence of more of weakness more than 4 weeks, if there is persistent bladder and bowel dysfunction, if there is sharp sensory level. It is likely to be another condition affecting the spine. If there is severe pulmonary dysfunction, fever at onset of neurological symptoms, increased mononuclear cells and polymorphonuclear cells in the CSF, all of these are prompting us that this will not be GBS in the patient. Now, in CSF is an important important for the diagnosis, and it rises early in the disease. Now, in CSF, the proteins is twice the normal, glucose is normal, and there is no pleocytosis. Less than 10 WBCs per mm³ are seen, and cultures are negative. Now, this condition wherein there are no WBCs but the protein is raised is known as cytoalbuminologic dissociation. Now, the diagnostic or confirmatory for GBS are the nerve conduction studies. The nerve conduction studies are best to be performed in the second week of illness. In the AIDP pattern, we find a demyelinating pattern, that is, there is decreased motor nerve conduction velocity, prolonged motor latency and conduction blocks. Now, why is this likely to occur? Because we know that our nerve is myelinated and the impulse, it jumps from one node to another node of Ranvier. Now, once there is demyelination, this saltatory conduction of impulse is affected and hence there is a slower conduction. So, there will be decreased motor nerve conduction velocity in the AIDP pattern of weakness in Guillain-Barre syndrome, and in the Aman pattern there are no features of demyelination seen, but other electrodiagnostic features are present. Now, it is said that the CSF and NCV are very important, but they are more important in the second week of illness. Nowadays, MRI is gaining importance in making a diagnosis of GBS. There is a thickening of the chorda equina. The intrathecal nerve root enhancement is seen mainly in the ventral roots. As I told you, the GM1 antibodies attack the ventral roots and hence the motor pattern in the weakness. So, MRI nowadays is also very important when we talk about GBS. Electromyography will show a denervation of muscle which is non-specific and not very diagnostic of the condition. Serum creatine kinase levels may be elevated or they may be normal, so they are also not diagnostic, and certain antibodies can be found, but these are also not diagnostic of the condition. So the most important are the nerve conduction studies, the CSF which shows a cytoalbuminologic dissociation, and the MRI. These are more important for the diagnosis. Now, once we know how to make a diagnosis of GBS, we can differentiate it from other conditions. That is the differential diagnosis of GBS. Now, one is the non-polio enteroviral illnesses or other viral myelitis. Why are we saying non-polio? Because now polio has been eradicated from India, so we consider about other take into consideration other conditions also. Certain other things like vaccine derived poliomyelitis have to be kept in mind because these can occur because of the vaccine, but as such poliomyelitis is not seen. So in non-polio enteroviral or viral myelitis, CSF pleocytosis will be seen. Now, second differential diagnosis will be an acute myasthenic crisis. Acute myasthenic crisis along with other neuromuscular disorders will present with weakness like this. Also, there are certain conditions like snake bite envenomation and botulism, but these will occur within hours. So that is how we can make a differentiation whether it is GBS or not. Now, acute transverse myelitis is one of, I would say, the most important differential diagnosis. Now, there is persistent bladder involvement in acute transverse myelitis, and also there is weakness. At the onset of weakness, there is fever present in it. Also, there may be a sharp spinal level in acute compressive myelopathies. So, this is how we can differentiate it from other conditions. There might be other neuropathies. Neuropathies, we can remember some of them metabolic ones like the acute intermittent porphyria, Lake's disease, which is a mitochondrial illness, certain toxic neuropathies like vincristine, thalidomide and other drugs causing neuropathies, certain infections like HIV, CMV, West Nile, these also cause neuropathies. Then there's an entity called critical illness polyneuropathy, which is caused because of prolonged ICU admission and bed when the patient is bedridden for a long time, and vasculitis, which actually affect the vessels which surround the nerve, the vasa nervosa, causing neuropathy. Myopathies like periodic paralysis and dermatomyositis can also be taken as a differential diagnosis, have to be considered when we talk about GBS. Now, when we talk about the treatment of GBS, first is that since we know anytime respiratory muscles might be involved, the diaphragm might be involved, we have to keep an ICU bed ready for the patient. So we need to do a muscle power charting. We need to check the patient's single breath count. Spirometry is rarely possible in our setting, so bedside testing in the form of serial single breath count. The weakness of the shoulder muscles will tell us that there's an impending diaphragmatic weakness that may occur. So all of this monitoring is important. Other than that, for the acute treatment, the most important that we use is the IVIG at a dose of 0.4 gram per kg per day for 5 days, or 1 gram per kg per day for 2 days. If the patient does not improve on IVIG, then we might try plasmapheresis and immunosuppressive drugs, but it is generally said that either give the patient IVIG or do a plasmapheresis. When we talk about CIDP, we have to consider immunosuppressive drugs and steroids, because this is a condition that is recurring. Otherwise, steroids as such do not have a role in GBS as such. They have a role when the patient is having neuropathic pain, and for neuropathic pain generally we prefer gabapentin. So IVIG, I would say, is the most important when we talk about the treatment of GBS. Otherwise, the treatment is mainly supportive. We have to take care of bed sores, the respiration, nutrition, pain management, prevention of DVT since the patient is bedridden, and secondary bacterial infections. So when we talk about the prognosis of GBS is excellent, but it depends on which variant of GBS it is. Aman, I would say, has a worse prognosis. It is seen in India that Aman variant has about 11 to 13% mortality as well. Now, GBS may even relapse in 4% children. Also, children will experience fatigue. It is a very common residuum that is seen. The spontaneous recovery occurs within 2 to 3 weeks, but it may take months.